So we are going to discuss about the examination techniques of B scan. So I have already said a little bit about it in our third video. This is fourth video. So in this axial, transverse, and longitudinal, there are three techniques. So let's discuss about it. So what is axial? Axial means directly in axis. It's very simple. And probe is directly over cornea. That's the very simple thing. Probe is directly over cornea. Yes, if eyes is closed, then yes, directly over cornea, but yes, over the lid. Patient fixating on the primary gaze. Patient do not fixate on the another gaze. It's just primary gaze straight off forward. So posterior lens surface and optic nerve head are placed in the center of the echogram. This is very important. So whenever it's we directly send our probe something like that in axis manner, then posterior lens surface and the optic nerve head are placed in the center of the echogram. So basically we place center of the echogram, then half upper part and half lower part. So this area is covered, isn't it? So it basically means this. So optic nerve head is used as a echogram center of the section. We normally do this. So we normally do optic nerve head examination, then we normally do axial length. So easiest to perform, one of the easiest technique to perform is axial. So axial means I have already told you probe definitely in the cornea. Mainly two variants in the axial scan: horizontal scan, which is marker in 3 o'clock or 9 o'clock for the right and left eye, and macular region is placed just below the optic disc. It's always there, isn't it? So vertical scan is 12 o'clock. This is vertical scan, this is horizontal scan, and this is oblique scan, isn't it? So oblique marker is always superiorly mark in oblique scan marker pointer. So can you see the marker in this black dot, this dot, this dot, this dot? Okay. So it's very important when the marker is placed, because if you place the marker, then in display towards that placement of marker is displaced in the upper part of the displacement, isn't it? Upper part of the that your monitor, isn't it? It's very important. Okay, so section allows other clock hours can be performed. It's depend upon just the clock hour. You do 180, you do 10 degree, you do in 30 degree, you do in 45 degree or 90 degree or 120 degree, whatever. It's depend upon you. Okay, so basically means this is the marker, isn't it? White line. So basically means, see in this picture you can imagine just this is a marker, and what are the position that USC places to retina is like something like this, isn't it? So basically, this portion of the retina is shown in the upper part of the USC scan. That's what I'm talking about. That's what I'm talking about. The marker, significance of marker. So okay, this is what I'm talking about, the marker. It's very important that you talk about the marker, you understand the marker. Okay, so this is the picture that I have taken from this book. This is a great book. So let me, so axial photograph A, what you are talking about in A, the photograph showing the correct gaze primary, basically means primary gaze, the eye should be in the primary gaze. Okay, second, schematic computer image in sound wave in horizontal scan, basically means, see, this is the marker, and along the marker that line is shown in the posterior portion of the globe, this line. So that's how important. And if it is marker in this position, then remember this portion is displayed in your screen upper portion. Okay, that's very important. So see, the horizontal scan echograph shows on the lens and the nasal portion posterior pole and optic nerve head and the temporal pole. So basically means the temporal pole, this is the temporal pole shown here, this is nasal pole shown here, this is optic nerve which is approximately middle, isn't it? So point to be noted is higher decibel gain level are needed to show the structure at the posterior segment, first thing, because of the absorption. Because of scattering and strong sound wave attenuation created by the lens, obviously lens absorbs. The pseudophakia is strong artifact created by the lens implant hampers the adequate visualization. That's why little bit strong higher decibel gain is needed. Significance: easy orientation, demonstration of the posterior pole lesion, and attachment of membrane to the optic nerve. It's very, very, very good for the examination of optic nerve, basically, and the posterior pole. Axial technique is very good. So basically, we see this is the A scan, okay, axial scan. So marker in the top basically means the top upper retina must be shown in the superior part of the display, and the lower retina must be shown in the inferior part of the display. And yes, definitely optic nerve in the middle, isn't it? So that's what I'm talking about. So this is, I have taken this picture from the book of Ophthalmic Ultrasonography and the ultrasound biomicroscopy or clinical guide. See, if it is nasally, then the upper portion is nasal retina, isn't it? The lower portion is naturally temporal retina, and center is optic nerve head, isn't it? That's a very simple. Again, the same book. So now see, in this picture, let me show you. This is superior nasal. If this is the superior nasal, then we place probe this. Superior nasal must be in upper part, and the inferior nasal must be in the lower part, in between this optic nerve, isn't it? Superior temporal probe is there, then it should be shown in the upper part of the scan, and the inferior nasal should be shown in the lower part of the scan. In between them, definitely optic nerve, isn't it? From same book. That's a very good book. So what is transverse and then longitudinal? Okay, what is transverse? The eye is looking in the direction of the observer's interest. Basically, eye is not in the primary gaze. It means the observer means we. It's an optometrist or ophthalmologist. Okay, probe is parallel to the limbus. It's very important point. Transverse means probe is parallel to the limbus, placed on the opposite conjunction surface. Probe marker superior if examining nasal or temporal, or nasal if examining superior or inferior. It's tricky, but I'll tell you in the picture. 6 o'clock hours examine at a time. So 6 clocks hour or examined at a time basically means 6 clocks hours we are examining in 6 clock hour. Limbus to fornix approach is used to detect any posterior pole perimeters, periphery, posterior pole to periphery. Basically means you move from limbus, here is the probe, and you move from limbus to the fornix, okay, to the fornix. So quadrant examination is done, basically means in 6 quadrant possible, and given lateral extent of the lesion. What do you mean by that? See, probe is orientated in this fashion, okay. It's parallel to the limbus, it's just parallel to the limbus, parallel to the limbus, and parallel to the limbus, and parallel to the limbus. The clock hour which the marker faces is always in the top on the screen. It's very important. Clock hour marker faces is always top on the screen. So marker means the top of the screen. The area of interest is probably done in transverse scan. It's always in the center of the right side of the scan. Okay. See, this is the main important point. Eye looking upward and probe is parallel to the limbus, isn't it? So basically means, what do you mean by parallel to the limbus means? So probe is parallel to the limbus. This is the limbus and probe is this. Then parallel to the limbus, isn't it? Taken from this book. So this is the picture what I want to show you. See, marker is here. Basically means parallel to the limbus, isn't it? This is the limbus. And whenever you throw this like this, sound wave thrown here, and whenever you move marker from here to fornix, at that particular sound wave moves from here to here, most periphery. Now you can understand this concept. If marker is here in superior portion, then definitely displayed in superior portion, and this portion is inferior portion, isn't it? So it's very important to understand this concept, okay. So whenever you sweep from nearby limbus towards the fornix, it moves here because eyeball is round structure, isn't it? So see, this is the case. First it's here in this case, and you move more and more towards the fornix, sound wave moves more and more periphery, okay, and it is shown in the scan. This possibility, and you can read the same thing. See, first it's shown parallel to the limbus, and as you move from a as you move from see ACD towards the fornix, and from D you move from closer to the optic nerve head, more periphery and more periphery, isn't it? That's what mean by moving towards the fornix. So basically means this. Okay, so just see, this is the probe parallel to the limbus, and you move from this zone. As you move more towards the fornix, you move more away from the retina towards the periphery of the retina. So longitudinal means, it's very simple. Longitudinal means, see, probe is 90 degree towards the limbus, perpendicular towards the limbus, and always remember marker towards the limbus. It's very important. Okay, marker directly towards the limbus. So looking direction observer's interest, optic nerve shadow is always at the bottom of the right side. Why it's always in the bottom? Because marker is towards the limbus, so optic nerve head is always in the bottom in this case, in longitudinal. 1 clock hour per time, it it's depend upon you. So determines the anterior posterior extent of the lesion. It's determined what anterior to posterior lesion extent of the lesion, and significance best for the peripheral tears and documentation of the macula. Let me show you. What do you mean by that? Probe is perpendicular to the limbus. It's perpendicular, isn't it? Whenever it is perpendicular, see, in this perpendicular, then optic nerve is always in the bottom. Okay, just remember this. See, this is the case. Probe is perpendicular to the limbus, optic nerve is towards the bottom and superior quadrant posteriorly. See, can you see optic nerve is towards the bottom, optic nerve is towards the bottom. It's very important, and you can definitely move from limbus to the fornix. See this case, this is very important, very tricky. 90 degree to the limbus and moving from there to periphery, isn't it? More and more towards the fornix, probe moves, it moves like this. It's very important. And then optic nerve is always in bottom. Optic nerve is always in bottom. Okay, always in bottom. It's not optic nerve. It's, I think it's different thing. What is this? Optic nerve is always in bottom. So basically, the B anterior longitudinal posterior margin to measure the anterior posterior lesion. Okay, that's a lesion. Fine. So this is the technique. Okay, I have taken this and this for the picture. This references is very great book. These are also great book. So try to understand techniques, which is very useful in your clinical examination. Okay, based on choose.